am doing this on my phone as well over here. So we are live. We are live here on StreamYard, going to YouTube and various other places. And we are now live on my phone for Instagram because I can never get it to work. So Alison Macbeth, welcome. Thank you so much for joining us again. This is a very, very complicated topic that we're talking about tonight, which is breast cancer and menopause. Now, you are not an oncologist, but you are a GP who works as a specialist for breast cancer, for people who've had after breast cancer, and you're also a menopause specialist. So I can imagine, and actually I've had a friend that I know this week who's been diagnosed with breast cancer, and I can imagine that it would be an overwhelming and incredibly scary diagnosis to get, and a lot of the focus will be on what we've got to do now.
Yeah.
But in doing that now, a lot of people will find that if they're on HRT, they're told that they have to come off it immediately, that they would have they'll either have treatments that will plunge them into menopause. How much information are they given about that?
I mean, I think it really depends on the clinic, but I don't think terribly much, because initially when a woman is diagnosed, you're throwing so much information at them and they're literally in survival mode, and that's absolutely fine. That's what, that's what we expect to happen. And we're, talking about their pathology, their surgery, if they need chemo, if they need radiotherapy, endocrine treatments, so many different treatments that we're discussing. And actually it's just hard enough trying to get the women to understand the pathology sometimes. And so trying to talk to them about their hormones and about what's going to happen with menopause symptoms down the line is just, they're not going to take it in, and it's just not a good time right at the very beginning to discuss that. The problem comes when they're on HRT at diagnosis, I think, because then they, for the most part, are being told to immediately stop it. So not even taper off it, but immediately stop it. So kind of overnight, they're trying to digest the trauma of having a breast cancer diagnosis, having to tell their family, their children, that sort of thing, and then cope with the immediate withdrawal of HRT, if they were on HRT at diagnosis.
Yeah, which is very, very difficult. Now, there are a lot of different types of cancer. So some of them are hormone receptive and some of them aren't. If you have a cancer that isn't hormone receptive, do you have to stop your HRT?
Well, some units will still insist that women stop it, and some are a bit more laid back and say, okay, you've got a triple negative breast cancer. It is not, I hate the term hormonally driven, but it's not an estrogen receptor positive breast cancer. So technically you don't have to stop it. The issue is if you've got hormone receptor negative breast cancer, then you can get recurrences or new cancers, and up to a third might be hormone receptor positive. And so that's why a lot of breast units are very cautious and still insist women stop it. Whereas other breast units are much more laid back and they're like, okay, it's hormone receptor negative, you can stay on it. I think it's really good, maybe holistically, if you're not insisting a woman comes off it immediately, like overnight, because if you've got hormone receptor negative breast cancer, invariably you're going to have chemo, and trying to get through chemo is a really, really difficult thing in itself. And then having to cope with the immediate withdrawal of your HRT. So, in the breast clinic I work in, I'll often say, look, we have a discussion about, okay, these are the pros of staying on it, these are the pros of cons of stopping it. So pros and cons, risks, benefits. And then we might say, okay, but maybe should we try and get through your chemo first with your HRT on board, and then see how things pan out. So that's your hormone receptor negative breast cancers.
Okay. Now, if you are in that situation, then when you're saying, okay, you've got to come off your HRT, you're going to have chemo, and you may also be put on what they would call an adjuvant therapy as well, which is sort of blocking your estrogen receptors. What can you do to relieve those symptoms of, the hot sweats, the insomnia, I mean, basically the mood, all of those things coming back? What options are at your hand then?
So I think the first thing to do is try and work out why you're having the symptoms. Are you having the menopause symptoms simply because you were menopausal or perimenopausal at diagnosis? Was it because you had to stop your HRT? Is it because of our breast cancer treatments, or is it all of the above? If it's to do with things like your endocrine treatment, your tamoxifen or your letrozole, then tamoxifen is very brand specific. And so what you can do is you can try changing your brand, changing the timing of the dose, splitting the dose, even sometimes halving the dose or halving the dose alternate days. And then if it's down to the aromatase inhibitors, then you can switch those 3 different aromatase inhibitors. There's anastrozole, letrozole, and exemestane. And what you can do is switch between them, because although they're all aromatase inhibitors, they'll all plummet your estrogen to what I say, 100-year-old lady estrogen levels, but they all have kind of different side effect profiles, so we kind of switch between them. And really the only way to kind of work out why you're menopausal or what's causing the menopause is what I do for all of my patients when they come in to see me in my menopause clinic and breast services. I'll get them to like fill out, oh, can you see that one of these menopause symptom questionnaires, get them to fill out one of these, and then we can try and work out, okay, what are your worst symptoms? Because invariably they'll have ticked pretty much every single box. And so what I'll say is, okay, this is a marathon, it's not a sprint, and there's always something that we can do to make you feel better, but we basically just kind of chip away and chip away and chip away. And so I'll say, okay, let's pick your top 3 symptoms and we'll work on them. And usually top 3 symptoms are things like your vasomotor symptoms, so that's your flushes, your sweats, hot and cold sweats, hot and cold flushes, your palpitations, or insomnia, or joint pains, or your genital urinary syndrome of menopause. So we kind of work on those. Sometimes I'll liaise with oncology, and it might be that we've turned off the ovaries with what we call ovarian function suppression. So that's those Zoladex injections or post-op. And that really, especially combined with an aromatase inhibitor, it really, really plunges you kind of into this crash menopause. And so often I'll liaise with them and say, okay, maybe just some time off the Zoladex. I mean, it all depends. Everybody's cancer is really individual. They're, not all cancers are the same. And so it really just depends on your pathology. And the other thing we often do is do medication holidays, which sounds much nicer than it is. Sadly, it's not a holiday in Ibiza, but we basically just take a break from the medication. And that's really, really useful to find out, okay, are your side effects the tamoxifen? Or the letrozole, or are you side effects simply because you're menopausal? I had to stop the HRT, and then you can go down all the non-hormonal route, your CBTs. I don't know, do you want me to talk through?
Yeah, because they are, I mean, a lot of people when they're looking for different options, they'll often think, well, if you're telling me to have CBT, you're telling me that it's all in my head, which is not really the case, really, is it? Because it's actually, I think CBT should be taught in schools. I think it's one of the most amazing sort of resilience type treatments that you could probably have for anxiety and all of those kinds of things. It's a really, really important thing. But it's also, they have shown, apparently, according to the Menopause Society in North America, effective for treating vasomotor symptoms, which is interesting, and hypnosis as well, which are 2 things that you would probably kind of think, ooh, I doubt that's going to work, but apparently they can help. Is it necessarily actually that they improve the vasomotor symptom, or decrease the amount of them, or is it just that they allow you to tolerate them better?
So the CBT for menopause, so there's lots and lots of different types of CBT, but the CBT for menopause symptoms, it reduces the perception of the symptoms, and it stops you going into this negative spiral where you start catastrophizing. You're thinking, oh my goodness, there's no way that I can tolerate all these flushes. Maybe in a meeting and you're getting flush after flush after flush, and so everything starts spiraling to a negative spiral. So what it does is it teaches you and it reduces the perception of them, so that then the next time, and this is a very simplistic view of this, but the next time you're like, okay, I know how to cope with this, I have the tools to cope with this, so then it's not nearly as bad as the next time, and each one gets a wee bit better. So that's a simplistic view of that. And if you look on the Menopause Society, which is North American Menopause Society, I don't know why they changed the name, and
Yeah.
British Menopause Society, they have a kind of non-hormonal consensus statements, and CBT for menopause symptoms is right up there. So it's got the first line evidence to help. And you're right, I think so many women think I'm just being fobbed off, I'm being told it's all in my mind, but actually it really, really works. I'm CBT trained for the BMS, but it takes a lot of time and actually a lot of effort from the women as well. So you've got to choose your women and choose your timing as well. And if you're right in the middle of chemo, it's probably not going to be nearly as effective because you've just got too much going on. We're really lucky. We've got the Maggie's Centre in Glasgow, and a lot of the Maggie's Centres are doing CBT group classes, and it's really, really effective. And then you've got your CBTI, which is your CBT for insomnia. And again, the Menopause Society at their conference last month were really talking about how beneficial this is. In Scotland, we're lucky enough to have the Sleepio app. Everyone can get that free. And in England, you can get that through Macmillan. And if anyone has ever listened to Dr. Zoe Shandel talk, she is a menopause and sleep specialist. And, you just listen to any of her talks and it talks you through what CBTI is and how to do it properly. So they're kind of like your non-medicinal treatments. And then you've got your non-hormonal treatments. So under the NHS at the moment, the medication with the first line or it's the best for vasomotor symptoms, and it also works for urinary symptoms, is oxybutynin, which is actually an old-fashioned bladder medication, and you take it at night. Now, I've actually I do have really good success with oxybutynin, and I only use the tiniest dose, because if you go higher dose, you'll often get kind of a bit dizzy or a very dry mouth. And you do have to be cautious in the elderly, because it can put them at risk of cognitive deficit and falls. So I wouldn't use it for maybe somebody, what's elderly? But maybe somebody over 65, then I would just be a wee bit cautious with using it. But about 2.5 milligrams oxybutynin at night works really well for flushes, and it also works for your overactive bladder and your urinary symptoms. You're up all night weeing, and of course, if you're up all night weeing, that gives you brain fog the next day. It puts your cortisol level up. It just, it just makes you exhausted. So you don't want to be doing any exercise or positive lifestyle interventions the next day. So poor sleep really impacts on your ability to function the next day. And the other thing with vasomotor symptoms is people think it's just a few flushes, you feel a bit grumpy, but vasomotor symptoms, as we know, is an independent risk factor for heart disease. And a lot of our medications that we use for breast cancer increase your cholesterol, increase your blood pressure, like the aromatase inhibitors, so increase your risk of heart disease. Or if we're giving you early menopause with our ovarian function suppression, that can increase your risk of heart disease as well. So the last thing we want is your sleep to be disturbed with all these vasomotor symptoms. So a lot of women say to me, well, I can put up with them. And I always say, don't put up with them. You don't need to put up with them. We can do something about it. Other treatment, sorry.
With the oxybutynin, is there a time limit on that you can use it for as well, because of those possible dementia risks? So is it time limited as well as dose limited?
Well, I've got patients that have been on it for a couple of years, but to be honest, I think most women, because of the dry mouth with it, will just maybe take it for 1 to 2 years. But I would just be very cautious as I say, I don't mean elderly, over 65 is elderly, but you just want to be really cautious about the cognitive and the falls risk. So I really probably would think twice about giving it to somebody at least over 70. And they're going to be up all night weeing as well, so you don't want them to fall over and break a hip. And again, a lot of our medications that we use for breast cancer are can give you osteoporosis or put you at risk of osteoporosis. So then if you're up all night weeing and at risk of falls, it's just this negative spiral of consequences. We're treating breast cancer with a sledgehammer at the moment, which is great. Our survival rates are really, really improving, but I think we're just completely forgetting forgetting about the collateral damage we're causing, you know, the increased risk of osteoporosis, the heart disease, you know, possible cognitive decline, the genital urinary syndrome of menopause, the impact it's having on relationships, ability to work, finances. You know, I could go on and on and on. You know, I'm always saying women are not just a set of boobs. And I must admit, I do find it a bit difficult in breast clinic because I've got my breast clinic brain on. So, you know, I'm a surgical speciality doctor in breast clinic. So I've got that part of my brain on, but I've got my women's health and menopause specialist part of my brain on as well. And the two of them are always fighting against each other. And I'm sure I drive my breast surgeons nuts because they're like, okay, we'll give you this for the breasts. And I was like, well, what about the bones? And what about the vagina? And what about the brain and the heart? So it's a constant kind of tug of war, which I have to say.
Absolutely. And then Michelle over here is saying, yes, 100% menopause after cancer can be brutal. We haven't got to the after cancer bit yet, but yes, this is, you mentioned vaginas there, and as we all know, vaginas are my favorite topic. In this sort of, you know, when you've just been diagnosed or you're on that sort of chemo and adjuvant therapy phase, can you use topical HRT for vaginal symptoms, or is that too early?
No, so you can use it anytime. So anyone that knows me knows that I'm a huge fan of vaginal estrogen. So essentially, if you have had or have a breast cancer, you can use vaginal estrogen. If you've got a hormone receptor negative breast cancer and are currently in treatment, you can use vaginal estrogen. If you're on tamoxifen, you can use vaginal estrogen. Where the waters get a bit murky and where people can often disagree is the aromatase inhibitors and vaginal estrogen. And the reason for this is you're trying to plummet your estrogen levels to negligible levels. But these actually are the women that need it the most because they are the ones with the most severe side effects. And again, we can't just purely look at breast recurrence risk. We've got to look at the woman's quality of life, her ability to be in a relationship, her ability to exercise and function and not be up all night weeing. I think a lot of the concern comes from this Danish paper that was out 2 years ago. And again, Dr. Holly Pedersen did a really good paper, a rebuttal for the North American Menopause Society about this trial, because it's this trial that, if you have specialists that have concerns about it, it's this trial that they bring up. But this trial was using data 97 to 2004, so over 20 years ago. And breast cancer treatment and vaginal estrogen has moved on significantly since then. They were using much higher doses of vaginal estradiol, which is E2. And only about 2/3 of the women in that study that were hormone receptor positive were on endocrine treatment, compared to today's, we're trying to get to near enough 100%. They overestimated compliance with all the treatments. There was no HER2 data. And as any breast cancer specialist will tell you, we know you can reduce your risk of breast cancer recurrence by up to 50% if you're HER2 positive and using anti-HER2 treatments with chemo. Well, there was no HER2 data in those trials. So again, those women weren't getting that treatment. So we just can't, and there was other things wrong with it as well, but we can't extrapolate data from that study to what we use now. And I do give women either estriol, which is E3. So this is ultra low dose vaginal estrogen in the form of Invadus, Blissol, or Vestin. And it's much lower and shorter acting, but it also has a greater affinity for the urogenital receptors. And that's really, really important to think about. And I think so many breast cancer surgeons don't understand that not all vaginal estrogen is the same. And just as we've no issue using tamoxifen in perimenopausal women, and tamoxifen can spike your estrogen levels to well over 1,000, and we don't worry about that because we know tamoxifen has a greater affinity for the breast receptors than estradiol. And it's the same with estriol. It's got a greater affinity for the urogenital receptors than the breast receptors. So it's not all just about dose either. It's ultra low dose, and there's no elevated serum levels of E3 or E2 after 4 to 12 weeks. But it's also that affinity receptor status as well. So I comfortably use it, or I use prasterone, and prasterone is a DHEA pessary. So it converts to estradiol and testosterone in the vaginal walls. And if you're on an aromatase inhibitor, then it stops it converting to estradiol. So it just stays as testosterone. And again, after 12 weeks of use, there's no elevated estradiol in the blood.
So if you're particularly concerned, that might be the best option then.
Yeah, it's a bit of a postcode lottery, though, the prasterone in the UK. I, prescribe it very happily in Scotland, and we don't seem to have much of an issue with it in Scotland, but certainly in England, I think it's a wee bit of a postcode lottery, which is a shame, and some women really struggle to get it.
How can we end this postcode lottery? I know it's a completely different topic, but it just seems absolutely insane to me that every 220,000 or so people, we have a completely different group that decides what people can and can't have. I just don't understand that. It seems like A, incredibly expensive, and B, incredibly inefficient.
Oh, I know. I mean, as you say, it just is so inefficient. We're the UK. although I don't want to get into politics and devolved medicine and we're devolved in Scotland.
So. Even in England itself, surely it can just have one everybody that makes its own decision.
Yes, one formulary for the whole of England. I know it's bonkers.
Yeah, it is. And I really actually want to know how much it costs to have all of those separate boards.
It must cost them a fortune, absolute fortune. It makes no sense.
Oh, makes absolutely zero sense. Anyway, we digress. So, all right. So we've got to the situation then when we've had our chemo. For the next 5 or so years, perhaps we might still be taking these adjuvant therapies, tamoxifen or an aromatase inhibitor. What are our options then for symptom control? I mean, we hear a lot about SSRIs as well, and clonidine, which the Menopause Society now doesn't recommend, but it's still recommended here. Gabapentin, ospemifene, I don't know where that one fits in, and the new one, fezolinetant. What do we have? What's on the table for us?
Okay, so what I usually start off with, and it just, again, you see, that's why we get them to do the menopause symptom questionnaire, because you need to know, okay, what are your main symptoms to know which medication to use. So, if it's mainly vasomotor symptoms and bladder, go with oxybutynin. If it is things like anxiety, joint pains, vasomotor symptoms, then I'll generally go with your venlafaxine and escitalopram. And it can be a really hard sell, because a lot of women understandably think, oh, you just pat me in the head and say I'm depressed and off you go. And I will always say, look, these are not in antidepressant doses. We start ultra low dose. So for the venlafaxine, the kind of lowest dose, and I always use a long acting, so I'll go 37.5 milligrams XL. And I only ever go to 75 milligrams XL. And escitalopram, I go with 5 milligrams to 10 milligrams. And you've got to be really careful with the SSRIs or the SNRIs for many reasons. But if you're on tamoxifen, then obviously we can't use paroxetine or fluoxetine. But what a lot of people don't realize is that in high doses, sertraline and duloxetine are moderate inhibitors of tamoxifen. So they're fine in standard doses, but high doses, moderate inhibitor. The problem comes when nobody realizes, and so maybe the woman is switched from aromatase inhibitor to tamoxifen, and then maybe she's really struggling with depression, so the GP bumps the dose up and up and up, and then she's been on tamoxifen and maximum dose sertraline for over a year, and you've had this moderate inhibitor. So if you're going to use an antidepressant, I always say, look, can we try and stick to venlafaxine or escitalopram, because they will not interact with any tamoxifen, and actually we know they're the ones that work the best for menopause symptoms as well. And if you look at the North American menopause non-hormonal consensus statements, venlafaxine and escitalopram are the 2 antidepressants that are generally recommended, plus low dose is it paroxetine, but obviously you can't use that with tamoxifen.
I had a question come in from a woman who was actually on both of those, who said, they haven't worked for me. What can I do now. So we're
So,
on.
yeah. So then second line, and the other thing actually with the antidepressants is you've always got to warn women, okay, they can make you put weight on, lower your libido, and often weight gain and libido are real concerns for women, completely understandable. So it's weighing up those kind of risks and benefits and side effects. And in some women, they can cause complete loss of ability to orgasm. That might be a temporary thing. So again, it's something we've always got to consider and have in the back of our minds. Second line, you can use gabapentin or pregabalin. Now, I sometimes will use a very low dose of gabapentin, maybe even 100 milligrams at night for anxiety and flushes and joint pains. The problem is when you get higher, you can get lots of problems with them. You can get fluid retention and weight gain and lower libido. And they're also controlled drugs and real significant issues withdrawing from them. So although they are effective, and especially if you've maybe got some peripheral neuropathy going on from your chemo, then you could try it. And I do have many patients that are on it, but I find it works better in the much lower doses, and as soon as you get to standard doses, that's when you run into all those side effects. And then we've got the new kid in the block that was licensed in the UK the end of last year, which is Veoza fezolinetant. I just say Veoza because I can't pronounce it properly. And that's been out in the States for actually nearly 2 years now, about 18 months, nearly 2 years. And it was supposed to be approved for use by NICE. We were all hoping it was going to be approved this summer, and the submission to NICE was delayed. And because it was delayed to NICE, then the Scottish Menopause Consortium won't approve it either. So we can't get it under the under the NHS at the moment, which is a real shame because we know it's really effective for your vasomotor symptoms, so your hot and cold flushes, sweats, and we also know that it is effective for sleep as well. So fezolinetant works on your neurokinin 3 inhibitors, which are basically the thermostat in the brain. And it works really, really quickly. And then there is another one that's in trials with breast cancer patients at the moment. So elazinitant, and that's Bayer that made that one. And they did Oasis 1 and 2 trials that were for non-breast cancer patients. And Oasis 4 is being done at the moment on breast cancer patients and women that are on endocrine treatment, so your tamoxifen, your aromatase inhibitors, and it was supposed to just run for 1 year, but it's going so well that they've extended it for another 2 years, and hopefully we're going to get some data out the beginning of or next year, next spring. Hopefully we'll get some initial data from that. Fezolinetant are starting trials in breast cancer patients at the moment, because at the moment it's although it's been licensed, it's not licensed for breast cancer patients, although I have used it privately off license, and it's been a game changer. But they are starting trials now. They were supposed to start them imminently, but again, I think they've changed the protocol. So I think trials are not starting with Veoza and breast cancer patients until next, maybe January time. But that's really exciting that we've got these treatments, and really hopeful that NICE will approve Veoza as soon as possible, because if you can improve the vasomotor symptoms and sleep, then you're halfway there for a lot of these women.
Yeah.
Because, again, as we talked about before, if you're not sleeping, then it really spirals into your next day. You've got your brain fog and exhaustion. And we know actually the best way to tolerate your breast cancer treatments, whether it's your chemo or whether it's your aromatase inhibitors, is exercise. But if you've not slept and are feeling exhausted and achy and brain foggy, then it affects your mood. You just don't feel like exercising. Maybe you make worse lifestyle choices, you put weight on, and everything spirals negatively. So if we can improve your vasomotor symptoms and sleep, and then improve your genital urinary syndrome of menopause, then hopefully you can feel better to exercise, then actually you're 3/4 of the way there.
Yeah, exactly. The very lovely Dr. Wendy is asking a question over here. Are you saying, Alison, you mentioned oxybutynin at night, not twice daily. Is it to keep side effects minimal? And is there ever a need to increase the days, increase to the twice daily? Thanks.
Yeah, and this is just personally, I stick to 2.5 milligrams at night, very rarely go to 5 milligrams at night. You can go to 5 milligrams twice a day, but I just find at these higher doses, just women don't tolerate it. We used to have the long-acting oxybutynin, but I think that's been discontinued. I know we had real difficulty getting that. That worked a bit better, but I certainly haven't been able to get it in Scotland for nearly a year now. Some specialists use a patch, and that's fine as well. I think it's just what you're used to using and what you normally use in your toolkit. There's no right or wrong, and so you can go up a dose, but just warn the women, look, these are the side effects to expect. If you can tolerate them, great, but if you can't, let's step back down to that low dose.
Okay. And in this period of time, obviously not if you were on an aromatase inhibitor, but if you were on tamoxifen, can you countenance starting HRT again at that stage or not?
Oh,
no, that's a complicated one, isn't it? I'm throwing the cat.
Grenades into. Well, yes. I mean, I have a lot of women that want to stay on their HRT even at initial diagnosis, or women that are maybe 6 months, 12 months down the line. If you look at strictly at the guidelines, HRT is contraindicated even in women who have had a hormone receptor negative, but that's following strictly by the guidelines. NICE has now said in exceptional circumstances you can give HRT to women if she's really, really significant menopause symptoms. And you're right, when is that time that you could consider it? There is conflicting data about theoretically having a woman on tamoxifen. You would think if you had her on tamoxifen and then gave HRT, that would be safer, because theoretically the tamoxifen should block your estrogen from the HRT on your breast cancer, your breast cell receptors. So theoretically, that should be safer, but there's conflicting data from various trials. So we just can't say it's any safer or not. The Americans have got Duav, which is a conjugated estrogen with a SERM, a bit like tamoxifen in it. And I think looking forward to that coming out in the UK if it does, because that might be an option. Again, there's no trial data on breast cancer patients, but hopefully there'll be observational data the more it's used. And so all we've got is basically you can't do hard and fast guidelines about, okay, you're 2 years down the line, you're safe for HRT, or you're 5 years down the line. The problem with estrogen receptor positive breast cancers is that they can recur anytime. So your triple negatives, if you can get through your first 2 to 3 years, then you've got a very low risk of recurrence from them. But estrogen receptor positive breast cancers can recur anytime from, straight afterwards to 20, 30 years down the line. It's a low risk of recurrence the more you get, but it's there year on year on year. So it's not cumulative, but there year on year. So you can never say, okay, you're 10 years down the line, it's now safe to give you HRT. You're always going to have an elevated breast cancer risk above normal population risk. And so it's that balance of, okay, why is it you want to take the HRT? Is it for your menopause symptoms, or is it because you've got osteoporosis, or is it because you're really worried about osteoporosis, or heart disease? And, there's various times when you might consider it. Say, for example, you had a young woman who maybe had a low risk hormone receptor positive breast cancer in her late 30s, and you've given her 5 years of tamoxifen. Well, you've not turned off her ovaries with the tamoxifen. And then she's finished her tamoxifen by mid 40s, and then she's having normal periods, so she's got her own hormones on board, and then she gets to late 40s and wants HRT. Well, it doesn't quite make sense to then turn around and refuse it, because she's had all her own hormones on board all that time at like way higher levels. And you and I both know in perimenopause, your estrogen levels can go even way over 1,000. So, you know, if we're just giving back tiny wee dose, to me, that seems actually quite sensible if you're wanting it to protect your heart or your bones. Most women do not die of their breast cancer. They die of the normal conditions of what postmenopausal women die of: your heart disease, osteoporosis, dementia, COPD, stroke, lung cancer. So we can't just focus purely on breast cancer recurrence risk. And I think, you know, I'm in a speciality where estrogen is seen as the root of all evil, and we're just terrified, and nobody wants a breast cancer recurrence, absolutely not. But I think we're not very good at thinking wider, thinking about the wider implications to the woman, not just the breast. We've got to think about her risk of osteoporosis, heart disease, her quality of life, her ability to have sex, her ability to be intimate with her partner, you know, every day. And it's so tragic. Every single day in clinic, I'm seeing women who have not been able to have sex with their partner since their diagnosis because of significant GSM symptoms. And then they get depressed, and then they put weight on, and everything's spirals.
Divorced because the relationship falls apart.
Yeah.
They go through all that treatment and then the whole thing falls apart because they can't have sex. Jackie over here has got a very, very important question, actually, coming back to this, and it is, we often think that HRT, you know, I mean, estrogen-only HRT has been shown to reduce the risk of breast cancer. Combined HRT has a minimal higher risk of the incidence of breast cancer. Jackie's question, though, over here is the type of estrogen is it the type of estrogen that has caused the cancer a consideration? Is the type of estrogen a consideration as a cause of cancer?
I mean, I don't think so. I think what it is, we think it's more the progesterone, which is why we're saying, you know, so it's in women who have never had breast cancer, then the WHI long-term follow-up showed if you were an estrogen-only HRT, you've got a lower risk of breast cancer than never users. And again, I think the BMS walked back a wee bit from that last year, and they now say it's probably a neutral risk. And those studies were actually done with conjugated estrogen. So, you know, we all think estradiol is actually safer, but most of the data we have actually is conjugated estrogen. But we think it's more the progesterone probably causing the kind of the proliferation, so the changes in the cells in the first place, and maybe it's the estrogen that then causes the abnormal cells that are there to grow.
Yeah.
We think that, and I think that's the concern.
So the estrogen might feed it as opposed to being the catalyst to start it.
Yes. Yeah, it might. Well, I hate the term feed, because you know what, so many of my patients all get told by maybe the radiologist or whatever, you know, when they get diagnosed, oh, it was your HRT that fed that cancer. And there's nothing worse than hearing that. And you know, and women often take that, just one comment, to their grave. And it's just, you know, and it's just not true. You know, so estrogen receptor positive breast cancers are just, you know, our own breast. A normal breast has got estrogen receptors on it. We don't call it estrogen positive breast cancer, we call it estrogen receptor positive breast cancer. So our own natural breast cells have got estrogen receptors on them, and estrogen receptor positive breast cancer is just a breast cancer that really hasn't changed much from its normal tissue. So it's kept its normal estrogen receptors. So it's not that, you know, your HRT's been fueling and you know, you've just basically got what we call a well differentiated breast cancer, so not changed much from its normal. And that's why most breast cancers are estrogen receptor positive, and that's why they do the best. It's the breast cancer cells that have lost all their estrogen receptors are what we call undifferentiated, so your triple negatives, that have a worse prognosis because they've lost all their normal features. And again, that was just a very simplistic way of discussing it.
Yes, this is a very complicated thing. The other thing about the thing in this as well is, you know, there was another comment that came up earlier and was saying, my mum was on HRT and she got breast cancer. So therefore, you know, thinking that this was a cause and effect. But lifestyle plays such an important role, doesn't it? When you look at that chart that came out from the Women's Health Concern, that, you know, being overweight is, I think, like doubles your risk.
Here we are.
Thank you very much for having that there.
Yeah. So I love this
I love
because
it.
yeah, because what it's so basically women 50 to 59, you've got 23,000 women over, so 23 to every 1,000 women will get diagnosed with breast cancer. That's your baseline risk. The old-fashioned synthetic estrogen progesterone from the WHI studies, that gives you an extra 4 breast cancers. We think actually with the body identical utrogestin, then, you know, the risk is a lot lower. And we think in the first 5 years of use, actually, there's no increased risk. And after 5 years, the risk is a lot lower. But yes, like an extra, so a glass of wine a day will give you an extra 5 breast cancers. If you smoke, you get an extra 3 breast cancers. If you're on the contraceptive pill, an extra 4 breast cancers. If you exercise, 7 less breast cancers. And if you have a BMI of over 30, and if you think about it, actually, it's very common to have a BMI of over 30 in the UK, especially in the west coast of Scotland. And that gives you that over doubles your risk. So you get an extra 24 breast cancers on top of your 23 you already had. So actually, it's lifestyle, you know, is the biggest risk factor. And this is my point with all of our breast cancer treatments. So for a woman who's had breast cancer and we are stopping her exercising or stopping her eating well or making her put weight on with our breast cancer treatments, or our refusal to give vaginal estrogen to aromatase inhibitor patients, you know, these women pile weight on, they stop exercising, they can't exercise. And in my view, I think actually we're increasing the risk of breast cancer recurrence rather than decreasing it by, you know, by stopping them doing the healthy stuff that we want them to do and that we know lowers their risk of breast cancer.
Yeah, which makes sense. Which then brings me to my final category of people, which are the ones who have finished their treatment and are now facing what could be, you know, 20 years or more as as cancer survivors. Are they okay to? Well, obviously, yes, you're going to say they can have the vaginal estrogen. Can they go back onto HRT? Can they start living happily, or do they still have to sort of swim through this as well? And I know what you're going to say, I think.
Yeah, I mean, there's no right or wrong. It really is an individual discussion about what type of breast cancer they had, what was your pathology, you know, are you really high risk, low risk, what other health conditions do you have? So why might you want to be taking HRT? As I say, if you've got osteoporosis on board, or you know, a high risk family history of osteoporosis or heart disease. So it's a really individual discussion. In my secondary care NHS menopause clinic, I have 40 minutes with women to make these decisions, and even then that's not enough. You know, in general practice we've got 10-15 minutes. I mean, there's no way that you can, or GPs should really make that decision. You know, if you've got a woman with breast cancer, refer them into a specialist menopause clinic. We've got a lot more time, and I will often, you know, go through everything with women, and then I'll maybe send them off, say, okay, listen to these podcasts, Menopause and Cancer. They've just done actually a really great series. Richard Simcock was on it, talking about HRT after breast cancer. Really, with our kind of modern breast cancer treatments and our body identical HRT, we think the risks are much lower, and current signals suggest it's not as unsafe as we think it is. And it really is a risk benefit discussion. So it should never ever be a absolutely no, you can't have it, or on the other hand, it should never be a, well, yes, everybody can have it, just chuck it at everybody. It really has got to be an individualized discussion. And you mentioned ospemifene before, and ospemifene, we could use that for GSM in a woman who's completely finished her treatment, but at the moment it's contraindicated if you're on things like tamoxifen or aromatase inhibitors. I've used it a couple of times, so I don't have much experience using it, because I will go with the vaginal estrogens or the presterones. The only time I really use it in women who maybe are traumatized at putting things into their vagina, you know, those that don't want to have vaginal estrogen or have, you know, significant vaginismus, that sort of thing. So they're very, very specific circumstances, but it gives you menopause symptoms. It gives you flushes and sweats. So, you know, for me, it's not really something that you know, it's way down at the bottom of my toolbox.
Yeah, interesting thing. So going back to the, you know, the things that can help vaginally. I mean, we're often told to use moisturizers or lubricants and those kinds of things, but so many of them. I did a little analysis of them a little while ago. I got this spreadsheet and I looked at the 20 top ones in the market, and I went through their ingredients. And my God, there are more than 200 different ingredients in those 20 top sellers. And some of them you're looking at and you're thinking, I would not want that anywhere. No. I wouldn't want it in my mouth. I wouldn't want it on my skin. I really wouldn't want it in my vagina. How do women pick something then that's actually going to be useful for relieving the symptoms if at that particular stage they're told they can't have, because we often hear too that, you know, women saying, well, my oncologist has completely ruled out any vaginal estrogen, so I can't have it. What can I do? Where do people find something that's actually going to work for them and that isn't hormonal?
Well, it's difficult because you see, if you go onto a lot of the cancer websites, they're still recommending the stuff that's no business being anywhere near your vagina. It's full of parabens and glycerol and sugar. To be honest, the one, you know, I will talk about, yes, but I am not funded by them in any way. I think people think I'm sponsored by them. I'm not. But you know, Nick Panny did a really great paper that looked at all the different vaginal moisturizers, and then that came out pretty much top. So I just stick with yes, it's prescribable under the NHS, and you've got your moisturizer. So what I say is, you wouldn't dream of not moisturizing your face or your body, so you should be moisturizing your vagina as well. So and everyone mixes up moisturizers and lube. So lube is for intimacy, for sex. Moisturizer is exactly what it says in the tin. So, you know, I just, if you you know, and there are other okay brands as well, but, you know, yes, it's prescribable. So, you know, start off with yes and see how you get on. I mean, not every single product is going to work with every woman. You just want to make sure that it's pH balanced, because our vagina should be nice and acidic. So you want it pH balanced, and
not pH balanced, the right pH.
Yes, the right pH.
Between 3.8 and 4.5. Anybody actually has it even written on their product.
Yes. And then basically you don't want it full of parabens and glycerol. So just be, you know, a real good detective on your labels. The problem is, as we all know, I think as we get older, our vision goes, doesn't it? So you're like, I'm like, oh, I was kind of peering at labels in supermarkets and shops and I can't see it. So that is a problem if your vision goes a bit dodgy. But yes, so your moisturizer, your lubricant, not washing with any harsh soaps, either washing with water or and like an emollient like Epiderm or Hydromol, and pelvic floor exercises to get the blood flow into the pelvis. A women's health physio are worth their weight in gold. So I always banging on about how you get a women's health physio, and most GPs have access to a women's health physio. There might be a long wait, but you know, I always say to my patients, please ask for a referral, or I do a referral to women's health physio, and that really helps getting like the blood flow to the pelvis and working it and strengthening up. And because a lot, you know, whether they've had cancer or not, they're still going to have weak pelvic floor. They still might have a kind of prolapse of the back passage, a rectocele or vaginal prolapse, or a cystocele, which kind of your bladder neck coming down. So you know, so you're going to have all those problems, and that's helped by a women's health physio. And then my favorite topic, vaginal estrogen, and I always just stick to estradiol, and we've got small trials, and yes, we don't have huge big data, but we've got small trials to show that it works and that it's safe. And also we've got the small Vibra trial that was a pilot trial on prasterone, and again showed it worked and it was safe. Yes, there's small trials, we need more evidence, but we can't let women suffer in the meantime, because I think what everybody forgets about is not only quality of life, but also risks of recurrent urine infection, urosepsis, risks of getting buckets full of antibiotics chucked at you, and then you get resistance to the antibiotics. It can lead to acute kidney injury, and your risk of dying from an admission with urosepsis is up to 18%. Your risk of dying with an admission with acute kidney injury secondary to antibiotics is up to 12%. All the vaginal estrogen studies, not any of them have shown an increased mortality risk with using vaginal estrogen. So it is just, we have to just get away from this, concern about recurrence. Nobody wants a recurrence, but we have to think of the bigger picture.
Absolutely. And given the bigger picture there, this is a lovely last question to throw at you, of course, is, given you are one of the medical advisors on the Menopause Research and Education Fund board, if all of the money in the world were thrown at you, or at least just a small portion of it, what study would you like to see done on that?
Using estriol in women on aromatase inhibitors. Absolutely. That's just, every day I'm seeing so much suffering in women that are denied treatment for their genital urinary syndrome and menopause on aromatase inhibitors. So for me, that is the one. Yeah, that's my top study.
Good. And would that be something that would be very long term? I mean, are we looking at how well it works, or whether or not there's a long term risk, or what would be your question?
So I think we want to know. Well, we know it works. I mean, I examine women in my clinic. I also have questionnaires, and so they tell me they feel better. And when I examine, they are better. So we know it works. But yes, trying to convince some other specialists that it works, because so often I hear specialists say, well, they're on aromatase inhibitor, there's no point in giving it because it doesn't work. Well, it does work. But I think for me, it is the safety. It is the trying to put people's mind at rest about the increased risk of recurrence. So yeah, safety and efficiency.
Excellent. All right, final thing. If you are a woman who's had a diagnosis and you're having these other symptoms, and once you've got past the sort of the initial shock and you're thinking about other things, how do you then broach this with your practitioner if they haven't broached it with you, to say, okay, I've got these other symptoms and I want to deal with them?
So your breast care nurse should be your best friend, and they're going to be basically your link into your breast team or your oncologist. So I always say first port of call is your breast care nurse. You can also speak with your GP. Some GPs are really, really educated in this and can be incredibly helpful. And I appreciate, I am a GP myself. You can't be a specialist in everything. So if you find that maybe you're not getting enough support from the GP, then maybe go and see another GP in your practice, or the practice nurse. Your breast care nurse can liaise with your GP, or liaise with the oncologist, or liaise with the surgeon. So first port of call, your breast care nurse.
Brilliant. All right. Thank you so much for that. Let me end this over here on Instagram. And on Instagram, people, you can look at the beautiful version of this on YouTube. I'll speak to you later. And thank you again. And when people want to find you, darling, where do they find you?
So I work at Health and Menopause. So I work privately through them, and I spend most of my time in the NHS in the West Coast of Scotland, and Women's Health GP in Highlands.
Wonderful. Thank you. And hopefully we will speak again soon.
Speak soon. Thanks so much. Thanks for having me.